Oh, hello, everyone. We'll get started. I'll get away from the speaker. I just wanted to say, if you have a question today, just raise your hand and we'll have it on a microphone so everybody can hear. And then if at the end, if you want to fill out that survey that's on that QR link, it's on the Whova app. Otherwise, on the back table, there's a QR code to fill out there. And then for those on virtual, if you want to just comment in the chat, we will answer those questions in person here. So without further ado, go ahead, take it away.
Introductions first, just kind of introduce ourselves. My name is Amanda Weinzettel. I'm the injury prevention epidemiologist with the South Dakota Department of Health.
My name is Caitlin Reimnitz. I am the Crisis Services Program Specialist with the Division of Behavioral Health.
And I'm Kelly Rumsa. I facilitate Lake Safety.
And I'm Nicole Schneider, the Senior Policy Analyst for the Department of Tribal Relations.
Next slide. Or do we have a clicker? Oh. Green button, I'm assuming? Maybe. I'm assuming, right? The green button.
Yeah, that doesn't want to work.
Ah, different clicker. Sorry about that. And then I just wanted to share kind of the trending data about suicide deaths in South Dakota over the last 10 years. You can see that we had 135 suicide deaths in 2012, and we had 202 suicide deaths in 2021. The 2022 death data isn't quite finalized yet, but the provisional suicide death count for 2022 is currently 192. And then just some of the basic demographics. So males make up the largest proportion of suicide deaths. And then among race, you can see that whites make up the largest proportion, but as we talked about, the American Indians do have a much higher rate of suicide deaths when we look at the rates. And then by age group, it's that 20 to 29 age group, but really you can see suicide does affect all age groups across. And then just wanted to share a brief map of the suicide death rates by county. This map, if you can't read the numbers, I'm sorry. But the darker the color, the higher the suicide rate is for that county. So you can really see that central part of the state has a much higher rate compared to other parts of the state. And we don't just look at death data when we're doing suicide surveillance in the state. We do look at many other data sources. As part of our suicide data to action work group that we have put together, we look at death data on a monthly basis, but we're also looking at EMS data. So anytime EMS receives a call for a service, they go out. We do look at that data, so for intentional self-harm, suicide attempts, so we're not just looking at that fatal data. And then we also have what is called syndromic surveillance data, and that is data that is being collected by emergency departments. They're reporting that. So if someone presents at the emergency department, it's based off that chief complaint, so when they first arrive to the ED, what they're being seen for. So again, kind of that intentional self-harm, suicide attempt data. So we really, pulling all these pieces together on a monthly basis to really look at our county seeing a higher risk of suicide, whether that's deaths an increase or is it increase in those intentional self-harm, non-fatal visits. And then we compile all that data, we discuss it. If we do think a county is seeing those higher numbers, that is when kind of passing on to the group of doing some outreach services. So I will pass it on to Caitlin.
Sounds good, thank you. So building off of what Amanda said regarding outreaching different communities, so we work to really engage our key stakeholders that are in the community, and based on the data that Amanda pulls and we discuss every month, whether that's the veterans, Native Americans, et cetera, whichever data that is, we really work to engage those stakeholders. And then once we figure out that data and analyze it, we then outreach the prevention providers, local hospitals, and community mental health centers to determine who needs to be outreached by who and who the main point of contact is. We then have a questionnaire that we all utilize to find out more what's going on in their community, what they know, what they don't know, as these stakeholders really do know what is going on better in their community than we do. After that, we then set up a meeting with them, with whoever that point of contact is, and we brainstorm ideas of, what's going on, what can we do to provide support, resources. So now I'm going to go into our website here. So our South Dakota Suicide Prevention website is really a one-stop shop for everything. I would strongly encourage you to visit it. It does have a lot of information on it. It's been designed to be a one-stop shop for all things related to suicide in South Dakota. On this website, you can find information about suicide, how to get help, and resources for survivors, toolkits for communities, schools, and colleges, population-specific information, information for professionals, interactive data dashboards to provide the most up-to-date suicide data. And under the state plans tab, there are more detailed information about the priority strategies, the outcome reports, and the 2020 to 2025 strategic plan. And you can also request trainings and materials under the Get Help tab. The trainings are free to everyone, and it's one of the easiest things that we can do to support suicide prevention in South Dakota. So these are a listings of our different trainings that are available. These trainings are the easiest way to prevent suicide because this is how people learn about the symptoms and the warning signs regarding suicide. In calendar year 2022, over 4,000 people were trained and nearly 150 trainings took place throughout the state. So these are some of the ones that we offer. We do a lot of mental health first aid, a lot of youth mental health first aid, and we've just recently started doing more teen mental health first aid and QPR. So how to request a training? You can go to the Get Help tab, and on that tab there is a request training, and that's where you can look through the list of the trainings offered and decide which one is best for your organization. They are really nice because you can get trainings for anywhere between 1 hour or 2 days, depending on your agency's need. We do encourage a 15-person minimum, but that's not a requirement, we'll work with you to help however we can to ensure that the training takes place. So a little bit more on our suicide prevention page. These are the different campaigns that we have. So we have the Be the One South Dakota, definitely geared more towards youth. It is also a little bit more general, but more geared towards the youth. Reach for Life is our Native American campaign. Our Safe Space is our LGBTQIA+ campaign, and then Every Member Counts, which is geared towards our veterans. So these are our different campaigns. We are currently working on revamping some of them to make them a little bit more up to date. We work a lot with communities and promoting these different materials, as you can order them online free of charge also. We have lots of different swag items, brochures, and other materials for each of these campaigns. And here's a little bit more on those. We do have our Be the One toolkits and Reach for Life toolkits, which they contain, I believe the Be for the One South Dakota has about 410 material items, so it's excellent for schools. The Reach for Life, I believe we've upped it to about 210, which is great. So we have a lot of those that we send out throughout the school year, amongst our other LGBTQIA+ and our veterans campaigns. So we can also refer to professional health. We do have 11 community mental health centers that provide outpatient services to children, youth, adults, and elderly residents with acute mental health disorders or serious mental illness. To ensure that the mental health services are available to all South Dakota residents, DBH designates counties to each CMHC, which functions as the CMHC service area, also known as the catchment area. And mental health and substance use disorder treatment services are available, including if you need assistance in paying for these services. And with that, I will pass it on to Nicole, who is virtual.
Good afternoon, everyone. I had some audio issues earlier, so I just want to introduce myself again.
Thank you.
My name is Nicole Schneider, and I am the Senior Policy Analyst in the South Dakota Department of Tribal Relations. While working with the Data to Action group, I became aware of the consistently higher rates of suicide experienced by our tribal communities, and I wondered how we could outreach those communities specifically. After some brainstorming, the tribal relations team decided to move forward with a traveling suicide prevention booth, and we attended our first event in December of 2021. Next slide, please. Since then, we have attended a variety of events in tribal communities across South Dakota, as you can see here on this map. Great Plains Tribal Leaders Health Board and Oglala Lakota College have invited us to participate in many of their events in Western South Dakota, and we really appreciate their collaboration as well. As you can see, we try to stick with communities with a high tribal population like Rapid City. We've been down in the Rosebud and Oglala communities as well. And we've been over to Sioux Falls. And if you would like a chance to see our booth, we'll be at the South Dakota Suicide Prevention Conference in August. Next slide, please. So as you can see in this picture, we wanted our booth to stand out to members of tribal communities. And with that in mind, we designed banners with Dakota and Lakota phrases, as well as traditional designs. I'm going to try to pronounce some of the phrases that we've used. And those phrases include Nis Nalasni, which means you are not alone. Wichoni Washte Wan Iyuk Champo, which means think about life. And Nita Wichoni Iyachukte Sni, which means don't take your life. We also designed our promotional items featuring South Dakota Suicide Prevention website and the Suicide Prevention Lifeline number. And those items include pins, stickers, keychains, and magnets. And many of our items feature an image of a dragonfly or a symbol of a dragonfly. While dragonflies symbolize many things to Lakota people, some key concepts that they can represent are protection, hope, and possibility. We wanted to provide a variety of items to reach youth as well as parents, grandparents, and other relatives who may be concerned about a family member, and we wanted to make those resources easily accessible to them. On this slide, I've also included some interaction data. I think anyone with experience in organizing events around prevention and mental health knows that increasing turnout can be difficult sometimes. One of our challenges has been finding events with a large turnout so that we can reach as many people as possible. However, we have made some changes to our booth with the goal of increasing engagement and interaction, which I'll talk about on another slide. Another challenge that we sometimes face is our small staff size, so we're not able to travel to every event that we would like to attend. And in addition to this data, I kind of want to fill out the full picture. We have heard so many stories from individuals and families who have lost relatives and loved ones to suicide. And we've also found anecdotally that a lot of people are not aware of the 988 number or the other resources are available. And that experience of our staff has really driven home why this work is so important. Next slide, please. So as you know, the Suicide Data to Action Work Group uses data to target counties for outreach. And this is some of the data that we provided to community leaders in tribal communities and kind of inspired us to develop our booth and directly target those tribal communities for outreach. As Amanda noted earlier, the rate of suicide in our American Indian population is quite high, and this data is just a tool for community leaders and for leaders within families to kind of help them combat that issue. Next slide, please. So looking to the future, we have implemented some changes in 2023 to increase engagement and interaction with folks who stop by our booth. We have updated all of our in-house promotional items to reflect the new 988 number. And we've also incorporated games and interactive activities to make folks think about how they can take care of their mental health during times of stress or crisis. So we have some smaller swag items, and we also have some larger swag items, like a water bottle or a flashlight. And in order to get one of those items, participants have to roll a dice and answer a question such as, who is one person you can call when you feel down? Or what are 2 ways that you cope with stress? And after they've answered the question, they can receive a Plinko chip. You can see the little board in the picture here. And that determines what prize that they can receive. We're hopeful that these activities will attract more youth to our booth in the future. And we also plan to attend events in some of the areas of South Dakota that we haven't been able to reach so far. We'd especially like to get to Cheyenne River, Sisseton Wahpeton, Standing Rock, and Yankton. Our tribal relations team is really looking forward to continuing this outreach to increase awareness of the resources available to folks facing mental health challenges. That's all I have to share today. So thank you for listening, and I will hand it over to our next presenter.
As I said, my name is Kelly Rumsa, and I facilitate our Suicide Prevention Coalition in the Watertown area. We kind of cover, we call Glacial Lakes, which kind of encompasses more than one county, but Watertown, Cottington County is our primary, but we do a lot of outreach. We started our coalition back in 2014. We had community professionals really concerned about mental wellness in our community. And so by their action, we started meeting and they determined that we needed to be doing some work in our community. And so what this slide represents is how we started back in 2014. And then what I'm going to take you through the process as to where we are now. And what we ended up doing in our community is that we saw a dramatic increase in suicides in our community. And so we felt we needed to find a way to reach our community, but we needed to know how to do that. We wanted to be mindful. We wanted to know where we could get them, where they live, work, and play. And so through support of Department of Social Services and also with local grant funding through our Watertown Area Community Foundation, we were able to assess our community and then provide a public health campaign that we felt has really empowered and has shifted some mindsets, and also we've seen some changes along the way. But it's been a long journey, but I really feel that what we've done recently has really brought our community together. And so I really emphasize this statement. We need to illustrate the importance of caring for one's mental health is important for every community member. And that's a hard task. We know that in our community, we're over 20,000 people. We're a blue collar community, but we have different pockets as other communities do. And so trying to get people to see what is outside of their norm is really what we're trying to emphasize, and to also recognize that anyone at any time can be struggling, and for them to identify and to understand what does that mean, and also to determine that stigma of we're very willing to help others out, but we don't take that time to help ourselves. So that is kind of what our focus has been over the last year and a half, 2 years. But we are data driven. Much of the work that we do in our community, we look at outcomes, we look at the why here, why now. And I know people don't really like all the data points at some aspects of it, but it really helps drive what we're doing. It gives us that purpose. It helps us to really show that what we're doing is making those improvements, because in the field of prevention, it's very hard to show those outcomes because it is long-term, because we're trying to change people's attitudes, perceptions, and then we'll see that behavior change. And sometimes that can take years. And so we look for what are those quick things or those short-term goals that we can see where we're starting to see that shift, where we can get community buy-in, where we can get them to understand why we're focusing on what we're doing. But also in that same sense, once we start seeing a shift towards the direction we want to go to, how do we maintain that? We need to get past that perception of we're trying to fix things. But what we're trying to do is make a change so that our community can be healthy and safe for our youth and for our future. So I'm very fortunate in our community. We have a great working relationship with a lot of community organizations and businesses and entities, and law enforcement is one of those. And they graciously share their data with us. And so this is just a snapshot of some of the data that we collect. We look at threats, attempts, and also completions, but we also take it further by looking at means. We look at different age groups. We look at gender. We really want to paint that picture of what we're seeing during different times of the year. Where do we maybe need to do some emphasis? Where do we need to do that education? Knowing what the means are, that helps us put safety pieces in place. It helps us to educate. And so really having that information gives us that purpose. And it's not to throw fear into it or anything like that, but it's to let people know this is what's going on and what can we do to address it. So as many experienced, we saw a dramatic change with our behaviors after COVID. What we kind of determined is COVID identified that we don't handle stressful situations very well in our community, and we saw a dramatic increase in suicides. And so for us, we needed to look at how do we address this, because it's impacting so many. One impacts a community, and in 2021, we had 12 deaths by suicide, and those deaths ranged from youth to elderly people. And so we knew that it impacted more than just one specific age group. It impacted more than just gender. And so we really needed to let the community know that we need to be addressing this as a community. It is something that we need to know how to talk about it. We need to know how to ask for help, but we didn't know where our community stance was on all of this. So to help guide us, we looked at what we have in the community for data, but we also looked at what our students are telling us. The emphasis in my work is primarily working with youth and young adults ages 10 to 24. So that has been my focus through my 25 years of prevention. And again, sorry, the data is a little hard to read with this slide, probably with the conversion, it got a little messed up, but we're fortunate. We survey our students every other year using the PRIDES survey, which is a national survey, which correlates a lot with the youth risk behavior survey that the state uses and also aligns with other national data. So we can kind of see those trends of what's taking place with our youth. And what we identified over the years, and this shows 2021, 2019, and 2017, is that we're seeing an increase with both our middle and high school students reporting thoughts of suicide and also making a plan. What we also looked at is the correlations of different things. And what we also recognize, we've been on a downhill trend with our substance use with our students, but the last year that we surveyed in fall of 2021, we started to see an increase with substance use. And so then we went to look at our adult arrest data. We also saw a shift change with more arrests in regards to alcohol and substance use as well. So we're kind of seeing that correlation of we're seeing reported of thoughts of suicide, we're seeing an increase in substance use. What is going on with our community? Do we need to be looking at healthy coping skills? You know, how are we dealing with the stress of something that we've never experienced before? This slide also shows looking at, and what I want to emphasize, because it's a lot of information on one slide, but if you look at the blue bar, what that is showing us is students that have reported thinking about suicide and correlating with a substance use. And so overall, what this slide is telling us, students who have thoughts of suicide are also using higher levels of substances. And so looking at that correlation is the substance use altering their mind, their thinking, and so they're being more impulsive, they're having those thoughts, or are they using substances to mask the pain or to mask the mental illness that they're doing? And so really, we don't know that true why, but we just know that there is that correlation that substance use and thoughts of suicide are very high among our youth. So what we know, through student data, through law enforcement, and with the funding that we received, we were able to do community surveys, and those were our perceptions of our community. And what we found with all of that we did is that we saw a significant increase in suicides. We knew that, but now we had the data to support that. We found that many Watertown adult community members who wanted help for their mental health would not seek it. The self-stigma and the uncertainty of what that would look like was a huge barrier to our community members. We also saw a significant increase with the community's concern of youth suicide, depression, and anxiety. So what that also told us is that if we gear it towards our youth, we're going to get more buy-in from our adult population. And that we also saw an increase with our youth. And again, so having that community perception and what the youth are telling us, we knew that was a focus area that maybe we could get that buy-in from our community members. So what this information helped us to do and helped us to create our public health campaign was looking at how ready was our community members are to talk about mental health issues. We were able to have a range, and so we needed to know where are we going to get their attention, what level, what information, what images, what words were going to get them to pay attention. We also needed to know how easy it was for them to access that information, or to know how to make it easier for them to access that treatment, or how to deal with a mental health concern or issue. We wanted them to know that it is something you can do, and this is how you do it, so walking them through that process. We also were able to identify what would motivate them to take action. We also identified what media outlets do they look at, because that's what's going to help us. Where do we need to place this information so that we know that our community members are going to look at it? And then where do they want to find it? We may know where they go, but where do they actually go if they're looking for help or for information? So with all of that, and with the help of working with a marketing organization, they helped us to align what we wanted to do with kind of that marketing strategy. And so our goal was to educate and connect stakeholders and our key audience members. We wanted to support those affected by suicide and mental health conditions. We know that we need to address the needs of our community. We need to take care of those basic needs, because if they are able to deal with their social issues or basic needs of financial, home, all of that, their mental health is going to be better. And that we need to be mindful of what we're sharing and what we're communicating with them, trying not to overwhelm, making it simple, able for them to be accessing it. And so we simplified it. You know, these are everyday things that people probably talk about, but making it okay to talk about, and making it recognizable with everyday things and everyday people that they come in contact with. And so our focus was, you know, encouraging our community members to ask directly. It might feel very uncomfortable, but really focusing on trusting your gut. If your gut is telling you something's going on, you're not putting something new into somebody's idea, you know, into their head. And so, and it didn't just have to be about suicide, but it's just like, hey, I noticed something's going on. Or, you know, I saw that you haven't been coming to coffee on a regular basis. You know, just trying to empower and to encourage and to make it those everyday conversations, and really not to be judgmental. What we did find is our community is pretty open to other people's needs and concerns. What they really did was judge themselves. They thought, what are other people going to think about me? And so we're really working and focusing on that aspect. And really what we're trying to do overall is to let people know when and how to access the resources when they need it. Again, when we're looking at prevention, people, you know, it's not on their radar. If it doesn't impact them personally, you know, it doesn't matter to them. I mean, it does matter to them, but it's just not something that they need at that time. And so when they're ready or when they're looking, that it's accessible for them to access. We also took a twist on talking with youth. You know, if we framed it with we're helping our youth, we're going to be able to keep them safe. We don't want to see the numbers that we've been seeing. And so really giving the tools and the trainings and the presentations to give that to our community. It's relationship building is really what it came down to, is knowing who can the kids go to in their school, out in their community, in their faith base, in their workplace. And it seemed like our kids have become some of the teachers to those in our community as well. And so these next few slides are just showing some of the materials that we created through our public health campaign. The images, the language, the words, all focus around the data that we received from our community surveys, what images that they would relate to. So we had the empty gas gauge. You know, you feel like you're low on empty people. How many people have rode that line of, can I get to where I need to go before I need to fill up? But not waiting for that light to come on. Also knowing that we're very rural, people drive around. And so when do you have that opportunity or that time to talk to somebody? We focused on local resources. We focused on, you know, with 988 kicking off, we're incorporating a lot of the resources that exist, just making it more known to people. And this is just some of our fun stuff that we had. So making it accessible for people in everyday conversation, giving somebody a chapstick, giving somebody a koozie when they're sitting outside talking, magnets, stickers, just different things like that, just to engage that conversation. Also in the process, we created an app. Really, it's taking what we have launched with our Glacial Lake Safe website, combining with local resources and making it easier access for people to get that hands-on, because we know people aren't always looking at their computers, they're on their phones, and so we wanted a place where people could get that information. One thing that is very helpful is that we have a safety plan right on there, and our area counselors really appreciate that. They can fill it out with the individuals that they're working with. They can save it. You know, they can download it, they can print it, people have it on their phone, they can go back and look at it. And it's the safety plan that is being promoted through 988 and through our state. And so again, we're just promoting those resources that exist. Probably one of our biggest accomplishments with this was our communications guidebook, and this is just a screenshot. It's on our website as well. But our target populations were students, men and young adults, and parents. And then we added a fourth section for local employers. So working with HR, working with their employees, what resources can they have available? But all of that lists everything that we saw, all of our campaign material, it's our posters, it's our flyers, it's different languages, it's different images that people have free access to that they can utilize that information that best fits for them. And then the last thing that I just wanted to leave with you, if you are in the Watertown area, we do an annual awareness walk, a remembrance ceremony, and ours is Wednesday, September 6th. It's always the first Wednesday in September, and it's just a great opportunity to show that support and unity within our community. And we just encourage anybody who supports or promotes or has had loss themselves. It's just a great opportunity for that, to see that support. And then this is just our contact information, and if anybody has any questions now, I think we can open it up for that.
Thank you guys for that. We're going to open up the floor now to questions. If you have a question, go ahead, raise your hand. Me or Jacob will bring you a mic. Virtual attendees, if you have a question, just go ahead, put it in the chat, and Jacob will read that off for you. Thanks.
Yeah, I saw you talking about like the means people use when they die by suicide. Do you know how many of the individuals who die were like using substances at the time of their death? Is that something you also check?
We do. That's something that we're trying to get more in, more specific data on. But talking with law enforcement, talking with the ER, talking with the counselors that work with the individuals or might be sent to the ER or doing a follow-up with them, substances play a large percentage of when they've attempted, when they have made that threat. So we know that substances really do impact that impulsivity and that access to it. I know with some of our counselors, if someone's at the ER, we have to wait a time period before they can do an assessment on them. And so when they go up after that 24 hours and does that assessment with them, individuals are like, I'm not thinking of suicide. I don't want to kill myself. And so having those conversations and finding out that because of that alteration of substances or the access to means increase that level. So very high correlation.
Just to follow up, are you collecting this also on the statewide level?
Yes, so we actually, the Department of Health received funding from the Center for Disease Control and Prevention back in 2018 to be part of the National Violent Death Reporting System. So now we have the South Dakota Violent Death Reporting System, and part of that is collecting more detailed information around suicides and also homicides that occur in the state. And with that, we collect death certificates, coroner reports, toxicology reports if they were done, and then also law enforcement reports if they're available. So we're trying to get more of that detailed information to kind of inform the prevention then. So yeah, we're still in the early stages of data collection. We have 1 year of data available at this point in time, which was 2020. So.
Yep, it would, go ahead.
I guess just wondering, now that we're going on almost a year of 988, do you have any numbers of how many calls go directly to 988 versus 911, and any kind of success stories or anything around that?
So I am the one that usually records all that, and I don't have an answer off the top of my head. We do collect the success stories that 988 shares with us, and I do believe they get, I don't want to give a number here that's not accurate, but it is up near that 80% of they get all the calls. If somebody does call into 211 or 911, those calls can be routed to 988. And a trained counselor is able to direct those calls. And they do a lot of that, and they have very good success rates. I would be more than happy to do some follow-up with you personally afterwards too, and can get you some more information on that if you'd like.
And you can also go with, if you go to the Helpline Center's website for 988 specifically, they have a dashboard. And so then you can go on and look by county or by bigger cities and see what those calls are that are coming in. And you can do it by different time periods and things like that. And so for me, I go and check Cottington County and Watertown, and we have seen a significant increase with calls as we've been promoting the number as well. And it also helps us to look at what are the calls that are coming in, and typically a lot of them are depression, anxiety, relationships, financial. And so then that helps us to look at then what do we need to be sharing this back out into our community, and what resources or what things do we need to be doing to help. And I think, you know, the reason of 988 is to have that partnership with 911 and 211, where if it isn't something that 988 can reduce that crisis in that time frame, then they can connect directly to our 911. And I know that for Watertown specifically, that we've had that relationship happen, and so then dispatch could go and check on the individual. So I think it's been very positive in the short time that we've seen that partnership.
There's a question online. I think it's for Kelly. What was the name of the app? that you
Oh,
referenced?
yep, it's called Glacial Lake, or it'd be GL Safe, and it's app. Probably the easiest way to access it though, what we found out, I am no by any means into technology or IT person, so this has been a learning curve for us. And so if you have an iPhone, you can search GL Safe and it will pop up. It's a little dragonfly, but if you have an Android like me, it's not as easy to access. So you do have to spell out GL Safe and kind of scroll down. But if you go to our website, humanserviceagency.org/GL Safe, we have it where you can click on the link right there and be able to download it. And we are going to be making some updates and changes to it as well, because some of the resources have changed. So if you think something's not accurate or you know of a resource, please let me know and we'll make those changes too.
Any more questions from our audience? One here? Cool.
I have a couple questions. One is, you'd mentioned gathering information about statistics about ideation, threats, attempts, completion. Do you gather that information from private counseling practitioners, or is it just community mental health centers and hospitals? How far does that reach?
I think is it
Yep,
for
I
you?
can answer it. For us locally, it's just those that call in. So those that would call into law enforcement, the calls that they would get. So those are reported. And so we know that there's probably more out there that we're not getting those calls in. We used to also collect data from our emergency room, but with just changes with coding and contacts, that way we don't get as specific information, but they are a partner with us and share that information. So primarily, most of our data comes from law enforcement for those who come in, because that's data that we can access. But always looking at ways to expand on that too, because we need to protect those privacy of individuals and things like that too. So, but it is something that we're trying to communicate more, working with our local providers in doing more of a resource share, or these are the scenarios that they're coming across. What can we do to help you to get the information to them?
Second question is, you'd mentioned the South Dakota violent death.
Yep, the South Dakota Violent Death Reporting System.
So the question I have there is, how much does the FBI report from reservations and the violence that's not reported to the rest of the state that happens?
Yeah, so unfortunately for that grant for collecting data from FBI, it's very, there is a bit of a challenge there. Just with some of the restraints they have with information they can share. We don't usually get a lot of information if FBI is involved, but if it was on tribal lands, then usually, you know, like tribal law enforcement will be involved, sometimes DCI. And then for other counties, it just depends on if they're big enough city, that then there'll be local law enforcement. If it's smaller, then usually it's the sheriffs.
So the numbers that you put up there really probably are underestimated greatly considering that your reporting system.
For suicide deaths.
Yeah, as suicide deaths and even with a violent.
Well, so how it kind of works with, so when someone dies, you actually have the county coroner who goes in, and that's what gets reported then to our Office of Vital Records, which is where we get most of our, that's what the death data is coming from, is our Office of Vital Records. So coroner could be a funeral director in a county or the local law enforcement agency, so it kind of just depends, but the coroner is the one who would be making that final manner of death determination.
Thanks.
Any more questions from our audience? Any virtual questions, Jacob? No? Okay. On that note, oh,
Thank you so much for all the information that been shared here. I just wonder, actually, considering the high suicide rate in South Dakota, maybe I wonder if you can share what is the strategy like in terms of policy or program services that coming from the state? And also, is there any possible public-private collaboration? In this sense, I know that many of you have been doing so much, I think from the bottom up. I think there's so many ideas has been shared so far, but I was wondering, you know, in terms of Department of Health, but also other state department, as this issue is kind of complex, not just like health issue. So I wonder if you can share your perspective on that. Thank you.
I can start and you can fill in maybe?
Sounds good.
Yeah, so as you saw with the data, we were seeing, very, very high numbers of suicide deaths over the last 10 years. We're seeing increases. And knowing that, you know, we're a small state, which means sometimes resources are limited. So knowing that as the Department of Health, we can't just tackle this problem ourselves. Yeah, we get some of the data that we can kind of help drive maybe where resources need to go. But that's really where kind of this suicide data to action work group really started. It was really knowing we needed to get more collaborative work going together. So that was pulling in Department of Health, Department of Social Services, and also Department of Tribal Relations to really kind of build up just state agency wise, but then I'll kind of let you take the torch for kind of what's other prevention.
Yeah. So the Department of Social Services, in particular, we meet with, as Amanda said, DOH and DTR and some other state agencies. And what our role is, that I'm understanding, is we do a lot of our outreach for trainings and for materials. We promote a lot of the QPR, mental health first aid, teen mental health first aid, youth mental health first aid. And so we do our outreach efforts through that is by reaching out to communities and connecting with them and asking, hey, what's going on in your community? How can we provide you these resources? Do we need to reach out to the helpline center and send you 988? Do we need to send you some Be the One or Reach for Life campaign materials? Can we offer and come and do a training for you? So it's really, for our part, we work one-on-one with that point of contact within the community and decide together what they need. And then we bring that back to our suicide data to action group, and together kind of come up with who those contacts are and how we want to go about that. I'm not sure if I missed anything more there.
I think so, unless Nicole's got any.
Insight.
We do our targeted outreach, as I mentioned in my presentation, and I think it's really just connecting with and empowering people in the community with that data to be able to respond to the circumstances that only they know about locally.
Any other questions? If not, thank you very much to our presenters. Please remember to fill out that session survey, and that's where you also get the CEU's credit too. So thank you very much.
Thank you.
Thank you.
The next session will begin at 12:15 here.
2:15.
Take
You
the
guys
one
can take
off.
a
Yeah.
quick break if you want to. We'll be back at 2:15.